Welcome, curious minds, to another deep dive. Today, we're not just scratching the surface, we're plunging right into the depths. We're aiming for true mastery of acute gastrointestinal hemorrhage. This isn't just about being well-informed, it's really about understanding the intricacies, the subtle cues and those critical decisions that define expert care in this field. Think of this as your definitive guide.
Absolutely. It's a cornerstone of emergency and critical care medicine. And often, what looks like a straightforward symptom can escalate really rapidly into something life-threatening. What's truly fascinating, I think, is the remarkable evolution we've seen, both in diagnostic precision and, therapeutic strategies. We'll meticulously break down the whole clinical approach, from the very first moments at the bedside right through to highly specialized procedures. We want you to really grasp the why behind every single decision.
Okay, so let's start right at the beginning. What exactly is gastrointestinal bleeding? Because it's a term it's broader than many might think. We'll lay down the basic definitions first, then really dig into the advanced concepts, the breakthroughs that have just profoundly shifted patient outcomes.
Right. So generally speaking, gastrointestinal bleeding, or GIB as we often call it, is really the umbrella term for any blood loss happening anywhere along that whole alimentary canal. That entire system, starting right from your mouth all the way down, that's the potential landscape for a bleed.
Okay, that's a clear starting point.
It's crucial. And to classify GIB, clinicians universally use a very specific anatomical landmark, the ligament of Treitz. It's this sort of fibromuscular band. It comes off the diaphragm, loops around where the duodenum meets the jejunum. Basically, it marks the transition point between the first and second parts of your small intestine.
Ah, okay. The dividing line.
Exactly. So any bleeding happening proximal to that ligament, upstream if you like, is called upper GIB or UGIB. And this category, it accounts for the majority of all GIB presentations. The common culprits here are things like peptic ulcer disease, PUD, esophageal varices.
Those are the enlarged veins in the esophagus, often linked to liver problems.
Precisely. And less often you might see bleeding coming from the pancreas, the liver, or the biliary system.
Got it. And if the bleeding happens distal to that ligament after that point.
Then we're talking lower GIB, or LGBUB. This type accounts for a pretty significant chunk, maybe 30% to 40% of all GI bleeds. And in the vast majority of these LGI cases, the bleeding starts in the colon. The most frequent sources there are diverticular disease.
Those little pouches in the bowel wall?
Yeah, exactly. Those pouches or angiodysplasias, which are abnormal, sort of dilated blood vessels. And beyond just location, we also classify G by how severe it is, how it presents clinically. That really guides the immediate management. For instance, massive GIB, that's a specific urgent classification. It means blood loss so bad it leads to hemodynamic instability, think severe drops in blood pressure, dangerous heart rates, or it forces an immediate blood transfusion just to keep things going.
And then there's occult GIB. That sounds, hidden. What does that imply?
Occult GIB is definitely more subtle. It reflects a hidden source. We use that classification when a patient shows up with anemia, specifically iron deficiency anemia, that keeps coming back or just can't be explained, even after a really thorough workup. Multiple endoscopies, advanced imaging, and everything comes back negative for a clear bleeding source. The bleeding's there, you see it in the blood count, but it's just unseen by the usual tools. That's why we call it occult or hidden. It's a real diagnostic challenge.
Now think about the broader impact. This is where it gets really striking. GI is the most common reason for hospitalization from any GI disease in the United States. That's not just a number. It represents hundreds of thousands of people needing urgent, often critical medical care every year.
And if we connect that to the bigger picture, the public health side, the economics, we're talking over 500,000 admissions annually just for GI. 507,000 to be precise. The financial cost alone is staggering. Total healthcare costs for these admissions, over $5.8 billion a year. That's a huge burden on the system, on patients, families, everyone.
And the average time someone spends in the hospital for this?
Anywhere from 3 to 6 days, typically. And the costs per admission, they range wildly from maybe $6,700 to over $20,000. It really shows this is far from a minor issue.
But despite those big numbers, there's some good news here, right? A story of progress.
Definitely. There's a really encouraging trend we've seen. The peak incidence of upper G specifically has steadily decreased by about 1% annually since the mid-1990s. That's a real testament to medical advancements making a tangible difference.
And the drop in mortality rates is just incredible. Historically, for UGB, you were looking at maybe 6% to 12% mortality now. It's down to less than 2%. That's an extraordinary leap in patient outcomes. It speaks volumes about the progress.
It really does. And this decrease, especially for UGBA, begs the question, why? What drove this massive improvement? Well, it's down to several game changers. The widespread use of proton pump inhibitors, PPIs, those powerful acid-suppressing drugs, that's been huge. Plus, increased awareness and aggressive treatment of Helicobacter pylori infection, a main cause of ulcers. And also, better education about avoiding NSAIDs, the anti-inflammatory drugs that can cause ulcers. These things directly hit the most common causes of peptic ulcers. So fewer ulcers, fewer bleeding complications. Simple as that, but profound effect.
But here's the interesting twist. While UG admissions have dropped, admissions for LG-PAY have actually increased over the same period.
Yes, and that really highlights the dynamic nature of this field. As we get better at managing one set of problems, others might emerge or become more prominent. It means clinicians constantly have to adapt. Diagnostic approaches, treatment strategies. It's an ongoing journey of refinement. Medical progress never really stands still.
Okay, so for anyone listening, maybe you're in training, maybe just deeply curious, understanding how medical teams jump into action during a GEEB episode is crucial. How does it typically present, and what's the absolute first plan of attack?
Well, GEEBing can show up in so many ways. It's a huge spectrum. On one end, it might be super subtle, maybe just unexplained microcytic anemia, small red blood cells suggesting chronic iron loss, or a positive fecal occult blood test finding microscopic blood you can't see. But on the other, much more urgent end, it can be massive acute exsanguination. The patient is literally bleeding out rapidly. Regardless of how it starts, a coordinated multidisciplinary approach is absolutely essential. This isn't a one-person job. You need a whole team. Emergency docs, intensivists, gastroenterologists, interventional radiologists, surgeons, all working together seamlessly. Stabilize, find the source, treat effectively, and quickly.
Let's really unpack the foundational framework then, the ABCDEs: airway, breathing, circulation, disability, exposure. This sounds like the universal checklist for any major emergency, the bedrock.
Exactly. In any crisis, airway patency and adequate breathing are always top priority. GEEB is no different. Think about someone vomiting large amounts of blood, severe hematemesis, or someone whose mental status is dropping because of shock, or maybe hepatic encephalopathy from liver disease. These things can seriously compromise their ability to keep their airway open, get oxygen in, get CO2 out if there's any doubt about the airway.
You intubate.
You secure it immediately, endotracheal intubation. But even that needs care, paying close attention to their hemodynamics because the procedure itself can sometimes make things temporarily worse if they're already unstable.
Okay, airway secured. Then we hit circulation, the lifeline. What are the immediate must-dos there?
Circulation support is absolutely vital. First step. Get good IV access, fast. That means 2 large-bore peripheral IV catheters. We're talking 14 or 16 gauge, big ones. You need those large lines for rapid fluid resuscitation and, crucially, for giving blood products quickly when needed. In truly massive bleeds, peripheral lines might not even be enough. You might need central venous access with special resuscitative lines designed for even faster infusion rates. And alongside getting access, consider invasive monitoring in severe cases, like an arterial line for continuous real-time blood pressure. It really helps guide resuscitation. Also, a urinary catheter is essential. It's not just about measuring urine output, though that's a key sign of how well the kidneys are being perfused. It also helps protect kidney function. Kidneys are very vulnerable in shock.
Without those fancy monitors right away, what are the bedside clues? What screams severe hemorrhage clinically?
You're looking for the body's reaction. Tachypnea, rapid breathing. That's the body trying to compensate for acidosis from poor oxygen delivery. Tachycardia, rapid heart rate. Trying to keep cardiac output up when blood volume is low. And then the more ominous signs. Hypotension, low blood pressure, agitation, confusion, any change in mental status. Those point to poor perfusion of the brain and other organs. Clear signs of severe hemorrhage.
I've heard that hypotension, low blood pressure, is actually a really late sign in bleeding. Is that true? And often a very bad sign.
Yes, that's an absolutely critical point. For anyone aiming for mastery here, understand this. Systolic blood pressure often doesn't drop below 90 millimeter Hg until the patient has lost a lot of blood, maybe 30% to 40% of their total blood volume, so frank hypotension. It's often a sign that cardiovascular collapse is imminent. It's harbinger of death, frankly. And what makes it trickier is that in some people, especially those on beta blockers that slow the heart, or the very young or very old, the classic signs might be blunted or absent altogether. They might just seem anxious, be breathing a bit fast, have cool skin. It can be very subtle until they suddenly decompensate completely. Their body's reserves just run out.
Beyond the vital signs, what lab tests do doctors order right away? And how do they use those results to know if the resuscitation is working?
Immediate labs are fundamental. You need a type and cross-match absolutely vital to get blood ready for transfusion, a complete blood count, or CBC, to check hemoglobin, hematocrit, platelets, a metabolic panel for electrolytes, kidney function, a coagulation profile, PT, PTT, INR, to check clotting. Liver function tests are important too, especially if you suspect varices from liver disease. And critically, we often check serum lactate levels, sometimes repeatedly.
Lactate, why is that so important?
Elevated lactate is a direct sign of inadequate tissue oxygenation. It means cells are resorting to anaerobic metabolism because they aren't getting enough oxygen. So seeing the lactate level come down, what we call lactate clearance, is a really important sign that our resuscitation efforts are working, that we're restoring oxygen delivery to the tissues. It's a key endpoint we monitor.
Okay, this is fascinating. So the hematocrit, the percentage of red blood cells isn't immediately useful for gauging how much blood was lost acutely. That seems counterintuitive.
It really does, doesn't it? But what's crucial to grasp, and often misunderstood, is that in acute severe bleeding, the initial hematocrit is not a reliable marker of the volume lost. Why? Because it takes time for the body to react and for fluids to shift from the tissues into the bloodstream to compensate. And it takes time for the IV fluids we're giving to dilute the remaining red blood cells. So the hematocrit can look deceptively normal, or only slightly low, for several hours after a major bleed starts. Relying only on that initial number can give you a dangerous false sense of security. Now, when we're talking about fluid resuscitation, especially for massive bleeding, using massive transfusion protocols or MTPs is absolutely critical. These are preset plans that get universal donor blood products, red cells, plasma, platelets to the patient rapidly and in specific ratios. This coordinated approach has proven survival benefits. While the ideal ratio for GYBs specifically isn't as well studied as, say, trauma, the evidence suggests mimicking whole blood might be best. Something like 1 unit of plasma for every 2 units of red cells, maybe adding platelets in too. And you have to remember, rapid blood loss itself messes up clotting. It consumes clotting factors, dilutes platelets. It causes or worsens coagulopathy. So aggressively trying to normalize the PUTI, PTT, fibrinogen platelet count is paramount. We're also starting to use things like thrombolistography tag or ROTIM. These are tests that give a more real-time picture of the whole clotting process, guiding more targeted transfusions. Not fully standard for JB yet, but promising. And physically getting all this fluid and blood in, we use rapid infusers. These machines push fluids in fast, and crucially, they warm the blood products, because getting cold absolutely wrecks your ability to clot. Hypothermia worsens coagulopathy. Ultimately, anyone with significant bleeding needs an ICU bed. Continuous monitoring, immediate access to interventions, it's essential. And we know resuscitation is working when we see clinical improvement, better mental status, good pulse, blood pressure over 90, and those endpoints like lactate clearing and good urine output.
This brings up a really important point, and one that feels almost wrong initially. The transfusion strategy itself, when to give blood and how much. You'd think more is always better if someone's bleeding, right?
It's definitely nuanced. And this raises a critical question that a really landmark study by Villanueva clarified. This trial compared a restrictive transfusion threshold aiming for a hemoglobin between 7 and 9 GDL versus a liberal one targeting 9 to 11 GDL, specifically in patients with acute UG.
And what did they find? Did giving more blood lead to better outcomes?
Actually, no. Quite the opposite. The restrictive strategy, aiming for that lower target of 7 GDL, resulted in significantly lower rates of death, rebleeding, and other bad outcomes compared to the liberal group. This really challenged the old more is better thinking for many JIB patients, but, and this is absolutely critical for mastery, that trial excluded the patients who were massively bleeding out, the ones who are hemodynamically unstable from the start. So for those with truly massive, life-threatening hemorrhage, the strategy is different. You have to prioritize rapid volume replacement with blood products to save their life. The restrictive target doesn't apply there. It's a different population, different immediate goals.
Okay, so you've stabilized the patient, hopefully, but the bleeding might still be happening. Now the detective work really ramps up, finding where it's coming from. How do doctors localize the source?
Exactly. Running right alongside resuscitation is the equally vital hunt for the bleeding site. Your first clues come from the history and physical exam. They point you towards a likely diagnosis. And the characteristics of the blood itself offer huge clues. Hematemesis, vomiting blood, or that coffee ground stuff overwhelmingly points to UPOB, though you have to consider swallowed blood from the nose or throat too. Melena, that black, tarry, foul-smelling stool, that means the blood has been digested. Usually it points to an upper source. proximal bleeding. But again, if gut transit is super slow, it could be from lower down. Over 90% is UPEEP, though, and hematochezia, bright red blood from the rectum. Most often it's something distal like hemorrhoids. But here's the kicker, the thing you absolutely cannot miss. A really brisk UPEEP with fast transit can also look like bright red blood per rectum.
So you always have to rule out an upper source, even with bright red rectal bleeding.
Especially if the patient is unstable, yes. Absolutely critical. Which brings us to the nasogastric tube, the NGT.
Seems like a simple tool, but vital.
It really is fascinatingly useful. First, it helps diagnose finds blood above the ligament of Treitz, confirming UGEB. Second, it helps treat in a way by irrigating the stomach, clearing out clots for endoscopy, and if you get bile back in the aspirate, that tells you the tube is past the pylorus, sampling duodenal contents too.
So if the NGT aspirate is clear and bilious, does that rule out an active UG?
A clear, non-bloody and bilious aspirate, yes, that effectively rules out an active UG. It's a very reliable negative predictor for ongoing significant upper tract bleeding. But, and this is important, it does not rule out a UGI source that has stopped bleeding. If the bleeding stopped hours ago, the stomach might be clear by the time you place the NGT, so it doesn't rule out a past bleed or a lesion that could rebleed. Okay, so after the NGT check, the next steps really depend on the clinical picture. How stable is the patient? How fast are they bleeding? The goal is always to localize the source before they become completely unstable. You want to avoid that scenario where you're forced into a procedure blindly without knowing where to look. That's high risk, low yield.
What if someone is just bleeding uncontrollably, crashing?
If someone is exsanguinating, moribund, and you haven't localized the source, there's no time for more diagnostics, they go straight to a hybrid operating room. That's where you have interventional radiology and surgery ready to go, side by side. They can do visceral angiography to find and maybe embolize the source, or the surgeons can intervene immediately. It's a rapid, life-saving move.
Okay, but for the stable patients, the ones who give you a bit more time, what are the high-tech imaging tools used for localization?
For stable patients, the multi-detector CT angiogram, the CTA, is really taking over as the first-line study for GG localization. Its power is its sensitivity. It can detect bleeding rates as low as 0.3 millioles per minute, provided you use the right protocol. That means 3-phase IV contrast, arterial, portal venous, delayed phases using fast, modern scanners like 64 slice or better. And crucially, no oral contrast, because that can obscure the vessels. CTA has fantastic accuracy, sensitivity approaching 100%, specificity over 90% for active bleeding. And compared to traditional catheter angiography, it might mean less radiation and less IV contrast dye overall.
I've also heard about the technetium 99 meta-labeled red blood cell scan, and that it can detect even slower bleeds.
You're absolutely right. The tagged RDC scan, as it's often called, has incredible sensitivity for very low rates of bleeding down to maybe 0.04 milliole per minute. That's tiny, so it's great for those slow oozing or intermittent bleeds that a CTA might miss. Another big advantage is you can keep imaging for up to 24 hours after injecting the tagged cells. This really increases the chance of catching a bleed that stops and starts.
But there has to be a downside, right? If it's so sensitive, why isn't it always the first choice?
That's the key strategic question. The trade-off with the tagged RBC scan is precision. It's highly sensitive, yes, but it's not very specific anatomically. It usually only tells you the bleeding is in a general quadrant of the abdomen, like somewhere in the right lower quadrant. It doesn't pinpoint the exact vessel like a CTA or angiogram can. So for a stable patient with a slow, tricky, intermittent bleed where other tests were negative, it can be really valuable to give you a starting point to guide a more focused endoscopy or angiography to that region. But it's not usually the first test for acute brisk bleeding where you need immediate localization for intervention. Right, so once you have a general idea of the location from clinical clues, NGT, or imaging, the next step is usually endoscopy, if signs point to the UGI tract, upper endoscopy, or EGD, as soon as possible. Ideally within 24 hours, maybe sooner for high-risk patients. It's both diagnostic and therapeutic. If imaging fails to localize and you ruled out UGB, then colonoscopy is next. If the patient is stable enough and can tolerate the bowel prep. And that bowel prep for colonoscopy and LGB, it's absolutely non-negotiable. You need a clean field. Any stool or blood left in there will completely obscure the view.
Think about trying to find a tiny bleeding diverticulum. Impossible if the colon isn't spotless. The only potential exception is a massive bleed, clearly coming from the very end of the colon, the rectum or sigmoid maybe, where a careful look might be tried without a full prep, but that's risky and often unhelpful.
So a squeaky clean colon is fundamental for finding the source, especially something like diverticular bleeding.
Absolutely fundamental, like finding a needle in a very messy haystack otherwise. To get that clean view, patients go through a rapid prep. Usually means drinking a lot of polyethylene glycol solution, maybe 4 liters over about 4 hours. Then the colonoscopy happens within an hour or two after finishing the prep. It's a large volume, so sometimes it needs to be given via an NGT. Prokinetics can help with nausea. During the colonoscopy itself, you always try to reach the terminal ileum, the very end of the small bowel, to rule out a source there. And using scopes with large channels for suction and good water jet irrigation is key to clearing any remaining debris. Meticulous prep and technique are everything.
What if the bleed isn't upper or lower? What about that tricky middle GI, the small bowel? That's notoriously hard to get to.
Right. If you've ruled out UGI and colonic sources, the small bowel is the next suspect. We sometimes call this middle jeb. It accounts for maybe 5% of acute jeb. Even here, CTA is still often the first test. But if that's negative and the patient is stable, you have more specialized options for the small bowel. The main ones are video capsule endoscopy, CT or MR enterography, push enteroscopy, and device-assisted enteroscopy like double balloon enteroscopy. Video capsule endoscopy is often the go-to first for stable patients once upper and lower are excluded. You swallow a tiny camera pill, it takes pictures as it goes through. Diagnostic rates are decent, maybe 35-67%, best if done during the acute bleed. Factors like being male, over 60, or hospitalized seem to increase the chance of finding something. You still need a full bowel prep. The main risk. The capsule getting stuck, maybe 1.5% risk, higher if you have Crohn's, tumors, prior surgery. You can use a dissolvable test capsule first if you're worried. CT or MR enterography are imaging techniques specifically designed for the small bowel. They use oral and IV contrast. They can actually be better than the capsule for finding tumors or inflammation, often complementary to the capsule. And if the capsule or enterography finds something, the next step should be push or device-assisted enteroscopy, because those allow you to do something therapeutically, not just diagnose. Push enteroscopy uses a long scope to get maybe 50-70 centimeters past the ligament of Treitz, finds the source in about 40% of obscure bleeds. Double balloon enteroscopy is more complex, but can potentially examine the entire small bowel. It uses balloons to sort of inch along. Diagnostic rates are very high, maybe 77-85% better than capsule, but it's technically demanding. And for patients with altered anatomy, like after bypass surgery, you need these device-assisted scopes to reach certain parts. Finally, the absolute last resort for ongoing, unlocalized small bowel bleeding requiring transfusions. Intraoperative enteroscopy, done during surgery. The surgeon helps guide a sterile scope through the entire small bowel. You look for the spot, mark it, and then either resect it or treat it endoscopically right there. Very invasive, definitely a last-ditch effort.
What about those truly stubborn bleeds? The ones that just keep hiding, even after all that? The obscure bleeding cases.
Yeah, obscure overt bleeding. Often, the cause is actually a common lesion that was just missed the first time around. Maybe a small angiodysplasia, maybe a tiny ulcer. That's why, paradoxically, repeating the upper and lower endoscopies is often the next step. A second look, maybe by a different endoscopist, finds the missed lesion in up to 35% of cases. If bleeding is ongoing and still obscure, the tagged RBC scan and angiography can still be helpful, but remember, they require active bleeding at the time of the scan. If it's stopped, they'll be negative. We used to do small bowel barium studies in ochroclysis. That's mostly replaced by CT enterography now. CT is great for bigger things like tumors or Crohn's, but it often misses those flat angiodysplasias. Still a diagnostic gap there. And then there's provocative angiography, giving drugs during the angiogram to make the patient bleed, to unmask the source. It's done, reported success in small studies, but clinicians are understandably hesitant to induce uncontrolled bleeding. Needs immediate surgical backup, a real sign of how challenging these obscure cases can be.
Okay, we've navigated the localization maze. Now let's dive deep into the specific causes and management for upper GI bleeding. Starting with that key division, non-variceal versus variceal.
Absolutely critical division. Non-variceal and variceal bleeding are fundamentally different beasts. Different causes, different diagnostics, different treatments. We have to separate them mentally right from the start. Non-variceal bleeding.
Peptic ulcer disease, PUD. Most people have heard of it. But just how big a player is it in G?
It's the undisputed heavyweight champion of Eugene, responsible for up to 2/3 of all cases. And if you have PU, there's about a 10-15% chance you'll have a bleeding episode, the root cause, an imbalance. Protective factors in the stomach and duodenum get overwhelmed by damaging factors. The two main culprits are H. pylori infection and NSA ague. Sometimes they work together. H. pylori is linked to maybe 77% of duodenal ulcers worldwide. It causes inflammation, weakens defenses, and NSAIDs. They mess up the mucosal barrier by blocking protective prostaglandins. They also seem to inhibit other protective things like nitric oxide. If you use NSAIDs regularly, your risk of PUD is maybe 15–20%. The actual bleeding happens when the ulcer erodes deep enough to hit a blood vessel, the really bad bleeds, often from duodenal ulcers hitting the gastroduodenal artery or gastric ulcers hitting the left gastric artery. Big vessels, big bleeds. Now, treatment for PUD has just been revolutionized, largely by prevention. Aggressively treating H. pylori, cutting back on NSAIDs, using safer alternatives like COX2 inhibitors, that's reduce the overall incidence. But the biggest game changer, proton pump inhibitors, PPIs, introduced back in '89. They are the absolute mainstay. They work by shutting down the acid pumps, the H plus K plus AT paste in the stomach lining cells. This suppresses acid production for a long time, up to 36 hours, keeping the stomach pH above 3, which is what you need for ulcers to heal and clots to stabilize. So after resuscitation, the next step for suspected UGB is EGD, the upper endoscopy. If the patient is high risk, unstable, sick, clearly bleeding heavily, you want that EGD done ASAP, ideally within 12 hours. Early intervention improves outcomes. Before the scope, patients should get a PPI, usually IV. Some evidence suggests giving a prokinetic drug like erythromycin beforehand can help clear the stomach, improve visualization, maybe reduce the need for a repeat scope or transfusions. And NGT helps diagnose, but it usually doesn't clear clots well enough on its own for a good view.
This forest classification sounds like a critical tool for predicting who's likely to rebleed after endoscopy.
Exactly. It's a standardized way endoscopists grade the ulcer's appearance to predict rebleeding risk. It guides therapy. High risk includes grade EVA, active spurting arterial bleed, EZA, active oozing, non-pulsal, and AA, a non-bleeding visible vessel in the ulcer base. All of these need endoscopic therapy. Intermediate risk is IEE, an adherent clot. You carefully remove the clot, see what's underneath. If it reveals a high-risk finding, you treat it. Low risk are I, a flat pigmented spot, old blood, and 3, a clean base. These generally don't need endoscopic treatment, just medical management like PPIs. Overall, maybe about a quarter of patients getting an EGD for UGIB will end up needing some kind of endoscopic intervention based on these findings. And if that endoscopic therapy fails, angiography is usually the next step. If angiography fails or isn't available, then surgery becomes necessary. Okay, medical management. All confirmed PUD bleed patients get PPIs. Starting high-dose IV PPI before endoscopy, like an 80-milligram bolus, then 8-milligram infusion for 72 hours, has been shown to decrease those high-risk findings at scope, reduce the need for intervention, and lower risks of rebleeding, surgery, and death. Continuing PPIs after endoscopy also helps. Interestingly, some recent analyses suggest oral PPIs might be just as good as IV after the initial period, but the studies are a bit mixed, so IV is still common initially for high-risk patients. Eradicating H. pylori, if it's present, is absolutely non-negotiable. It dramatically cuts the risk of rebleeding. You must confirm eradication later breath tests, stool tests, or repeat scope biopsy usually 4 weeks after antibiotics finish and after stopping PPIs for a bit, and once it's gone. No need for long-term acid suppression, just for the ulcer history. The rebleed risk drops to about 1.3% without it. You also need to stop any offending meds, NSAIs, SSRIs, and possible, if someone absolutely has to restart an NSRI. Use a Codex 2 selective 1 plus a PPI. That combination has a much lower rebleed risk, near 0% in one trial versus almost 9% with the QX2 alone. Eradicating H. pylori first makes NSAIDs safer too. Aspirin is a tricky one, especially for heart patients. If it's for primary prevention, preventing a first heart attack, the GIB risk usually outweighs the benefits, so you stop it. But for secondary prevention, someone who's already had a heart attack or stroke, they should generally restart the aspirin, along with the PPI, within about 1 to 7 days after the bleeding stops. A key trial showed restarting aspirin actually lowered mortality significantly in these patients, 1.3% is 9% at 30 days, despite a small, non-significant increase in rebleeding risk. The heart benefits usually win out here, if they're on a PPI.
That's incredibly detailed. So during the endoscopy, how do they actually stop the bleed? What are the tools they use down the scope?
It's quite amazing what they can do. There are several techniques. Injection therapy, thermal coagulation, argon plasma coagulation, APC, mechanical clips, even fibrin glue. The standard recommendation now is to use either thermal therapy or clips. often combined with epinephrine injection, and that combination is key. Epinephrine alone, injected around the bleeding site, can stop the bleeding temporarily through vasoconstriction and tamponade. It works initially almost 100% of the time, but the rebleeding rate is very high if used alone, so it must be combined with something else, heat or a clip. Injecting a larger volume, over 13 millisl, seems to help with initial control, maybe enhancing that tamponade effect. Thermal therapy uses heat to seal the vessel. Options include bipolar cautery, heater probe, or APC. They're all similarly effective at achieving initial hemostasis, reducing rebleeding, surgery need, and mortality. Hemoclips are mechanical clips that physically pinch the vessel closed. They're great for spurting vessels' immediate control, but they can be tricky to apply on scarred or angled tissue, take longer since you deploy them one by one, and a badly placed first clip can block subsequent ones. The big advantage, though, they show up on X-ray, helping guide angiographers later if needed. Less common now is sclerosant injection, like absolute alcohol. It works, but risks tissue damage. Now, if an ulcer does rebleed despite initial endoscopic success, that significantly increases mortality risk. High-risk patients need close ICU monitoring. A second attempt at endoscopic therapy is usually recommended, and it's successful about 75% of the time.
So, endoscopy first, maybe a second time if needed. When does angiography come into play?
Angiography is both diagnostic and therapeutic. It's considered if endoscopy fails to stop the bleed, or if the source just couldn't be found endoscopically. Access is usually via the femoral artery. For UGO, you typically look at the celiac artery and its branches, first left gastric, gastroduodenal, as that's where most ulcer bleeds originate. If nothing's found, you might check the SMA or IMA too. Those endoscopic clips placed earlier. Invaluable road signs for the angiographer to find the right spot quickly. We mentioned provocative maneuvers before giving anticoagulants during the procedure for obscure bleeds. Risky, needs surgical backup. Once the bleeding vessel is found, transcatheter arterial embolization, or TAE. The goal is superselective embolization block only the bleeding vessel, preserving flow elsewhere to avoid bowel ischemia. We use various things to block the vessel: tiny metal coils, PVA particles, gel foam, which is temporary, it dissolves, liquid glue, special plugs. Coils and PVA are most common. Success rates are high. For UGB embolization, maybe 44-100%, depending on the study and situation. For LGB, often 88-93%. Vasopressin infusion used to be more common. It constricts arteries, reduces flow, but embolization is generally better now. Vasopressin has downsides, potential heart effects, high rebleeding rates when stopped, needs prolonged IV access. It might still have a role for diffuse bleeding or as a bridge to surgery if embolization isn't possible.
Even with all this tech endoscopy, angiography surgery is still needed sometimes for bleeding ulcers. About 10%, you said.
Yes, that's right. About 10% still end up needing surgical intervention. The key is identifying who's likely to fail non-surgical therapy early on. Predictors of failure. The Forrest classification is the best. Active bleeding at scope, large ulcers over 2 centimeters. Ulcers in tricky spots like the posterior duodenum or lesser gastric curve near big arteries. These patients need closer watching, maybe earlier surgery. Clinical judgment is vital. The traditional triggers for surgery, still relevant, though maybe applied less rigidly. Needing ongoing transfusions, maybe 6 units or 8-10 in younger folks. Endoscopy failing to stop it. Rebleeding after initial stabilization, especially after 2 endoscopic tries. Shock with rebleeding. Continued slow bleed needing 3 units a day. Also relative factors. Rare blood type, patient refusing transfusion, shock on arrival, older age, lots of comorbidities, or chronic gastric ulcer where you worry about cancer. Okay, surgery for duodenal ulcers. Usually need to open the duodenum, a longitudinal duodenotomy, then find the bleeder. Suture ligation with non-absorbable stitches. Posterior ulcers hitting the gastroduodenal artery. Need stitches above and below the bleed point. Maybe a medial stitch for pancreatic branches. Close the duodenotomy transversely so it doesn't narrow. NGT above, feeding tube below. Maybe reinforce with momentum. Drain if worried about leaks.
And those acid-reducing operations we talked about, vagotomy, gastrectomy, you said they're mostly history for bleeding ulcers now?
Largely, yes. A huge shift. We used to do them routinely if the patient was stable to prevent recurrence. Pyloroplasty plus truncal vagotomy was common for duodenal ulcers, but with modern H. pylori treatment and PPIs, ulcer recurrence is so much rarer. The need for these big, definitive, acid-reducing surgeries for bleeding PUD has plummeted. We mostly just fix the bleeding vessel now. Gastric ulcers are a bit different surgically. The initial step is gastrotomy, suture ligation, but that alone has a 30% rebleed risk. And remember, about 10% of gastric ulcers are malignant. So generally, you resect the gastric ulcer, not just oversew it. A distal gastrectomy, removing the ulcer, is often preferred over simple excision, which has a 20% rebleed risk. In high-risk patients, maybe just ulcer excision plus vagotomy pyloroplasty. Proximal stomach ulcers, tougher. Big resections like near total gastrectomy are very risky acutely. Maybe a distal gastrectomy including a tongue with the ulcer, or vagotomypileplasty plus wedge resection or oversewing. Always think malignancy with gastric ulcers. Other non-variceal UGIB causes.
Okay, moving beyond ulcers, what about bleeding from esophagitis, inflammation of the esophagus?
That's actually an infrequent cause of significant non-variceal UGIB. Most often, esophagitis comes from GERD, acid reflux causing inflammation, and maybe superficial ulcers. Usually leads to chronic blood loss, anemia, positive stool tests. Acute massive bleeding is rare, can happen sometimes with infectious esophagitis, especially in immunocompromised folks, or from meds, Crohn's, radiation. Treatment is mainly acid suppression. If there's acute bleeding, endoscopic control heat, cautery usually works. Treat infections if present. Surgery is almost never needed. Stress-related gastritis. This involves multiple superficial erosions, usually in the stomach body. It's acid pepsin injury plus weakened defenses, often from shock, low blood flow, NSAIDs, chemo. Historically, this was a big problem in critically ill patients. Cushing ulcers with head trauma, curling ulcers with burns. Significant bleeding was common before we got better at shock management and started using prophylactic acid suppression widely in ICUs. Now, if it does bleed, acid suppressive therapy usually works. If it fails, which is rare, you might try octreotide, vasopressin, endoscopy, or even angiographic embolization.
And those radical surgeries near total gastrectomies used to be done for this too.
Historically, yes. Things like vagotomypileplasty with oversewing or near total gastrectomy were done for severe refractory stress bleeding. But mortality rates were sky high, up to 60%. Thankfully, with prevention and better medical care, those surgeries are incredibly rare today for stress gastritis. A real success story. Mallory Weiss tears. These are partial thickness rips in the lining near the GE junction. Classic story is an alcoholic patient after intense retching or vomiting. Forceful abdominal contraction against a closed cardia tears the mucosa. They account for maybe 5–10% of UGIBs. History suggests it. Endoscopy confirms it need to retroflex the scope to see that area well. Most tears are on the lesser curve. Good news is most stop bleeding on their own. Supportive care, acid suppression works in over 90%. Mucosa heals in about 72 hours. Severe cases. Endoscopic therapy, injection, heat, clips. If that fails, maybe angiographic embolization, often with something absorbable like gel foam. Surgery, high gastrotomy, and suturing is a last resort. Always rule out varices, too. Recurrence is uncommon.
Gastric antral vascular ectasia.
Yeah.
GAVIAs. That watermelon stomach name is memorable.
It is visually striking. You see these dilated little veins forming linear red streaks that all point toward the antrum. Looks like watermelon stripes. Severe hemorrhage is rare, actually. Most patients just have persistent iron deficiency anemia from chronic slow blood loss. Treatment is endoscopic therapy for the anemia or transfusion needs. Argon plasma coagulation, APC, works really well, over 90% success. If that fails repeatedly, surgical entrectomy removing the antrum is the fix.
Dulifoid lesion. You mentioned this is tricky to find.
Extremely tricky. It's a vascular malformation, basically an abnormally large artery running very close to the surface, usually in the upper stomach near the GUJ, but can be elsewhere. The mucosa erodes over this big vessel, 1–3 millimeter diameter, and it bleeds. But the mucosal defect itself is tiny, maybe 2–5 millimeters, often no ulcer around it, so hard to spot if it's not actively bleeding. Because the underlying artery is large, the bleeding can be massive. Endoscopic control often works initially, thermal therapy, sclerosants, clips, success rates 80–100%, if endoscopy fails. Angiographic coil embolization is usually next. Surgery if all else fails. If the endoscopist tattooed or clicked it, that's a huge help for the surgeon to find it. Open the stomach, oversew the lesion. Rarely, if you can't find it, maybe a partial gastrectomy.
Hemophilia bleeding from the bile ducts. Sounds unusual.
It is uncommon and often tough to diagnose, usually related to liver trauma, recent biliary procedures like ERCP, or liver tumors. Incidence is slowly rising with more advanced endoscopy and liver procedures. Suspected if someone has gibbet plus right upper quadrant pain and/or jaundice, especially with that kind of history. CTA with an angiography protocol is often the preferred test if unsure. Endoscopy might show blood coming from the ampulla, where the bile duct enters the duodenum. Angiography is the gold standard for diagnosis and treatment, usually the first step if bleeding is brisk. Need to check portal vein patency if embolizing. Surgery is rare, maybe for infected pseudoaneurysms. Malignancy in the upper GI tract. Usually causes chronic anemia or positive stool tests, not massive acute bleeds. But sometimes persistently bleeding ulcers can be cancer GSs, adenocarcinoma, lymphomas. Endoscopy can often control the bleed temporarily, but rebleeding is common. Once diagnosed, surgical resection is indicated either curative or palliative, depending on the situation and patient stability.
Inflammatory bowel disease, IBD. We usually think lower GI. Does it cause you jib?
You're right. UGI from IBD, specifically Crohn's, is exceedingly rare. Very few reports of duodenal Crohn's eroding into a vessel. If it happened, you treat it like any other bleeding ulcer. Most bleeding from IBD is self-limited LGIB from colitis or ileitis, usually responds to medical therapy for the IBD itself. So UGI from IBD, very unusual.
Aortoenteric fistula, AEF. Sounds terrifying, the aorta bleeding straight into the gut.
It is devastating, usually fatal. Represents a free rupture of the aorta into the bowel. Two types. Primary is rare, aneurysm eroding into bowel. Secondary is more common after aortic graft surgery, 0.44% risk. Can happen days to years after surgery, median about 3 years. Usually involves a pseudoaneurysm at the graft suture line, often with infection eroding into the duodenum. With endografts can be failure, leak, or erosion. Must suspect AEF in any bleeding patient with a known AAA or prior aortic surgery. Bleeding is often massive, fatal without immediate surgery. Often preceded by a sentinel bleed, a smaller self-limited bleed hours to months before the big one. If you suspect AEF, CTA is the first-line test. Much better sensitivity than EGD, around 79% on EGD, and an at-risk patient is highly suspicious. CT might show error on the graft, pseudoaneurysm, contrast leaking into bowel. Treatment: immediate complex surgery. Like the aorta, remove the infected graft, debride everything, do an extra anatomic bypass. Assume infection needs long-term antibiotics. Endovascular repair might be a temporary bridge sometimes.
Hemosuchus pancreaticus. Never heard of that one. Bleeding from the pancreas itself.
One of the rarest UGB causes. Bleeding into the pancreatic duct, then out the ampulla into the duodenum, usually from a pancreatic source malformation, duct ulcer, or often a pseudocyst eroding into a pseudoaneurysm nearby. Angiography is key here. Gold standard for diagnosis, first line for therapy. High success rates, 75 or 100%, low mortality. Surgery for the underlying pancreatic issue, like a pseudocyst, is less common now, but might use intra-op ultrasound or pancreatoscopy if needed. Endovascular has largely replaced open surgery.
And what about procedure-related bleeding? Iatrogenic causes.
Absolutely. PEG tube placement feeding tubes can bleed up to 3% of the time, often just skin vessel pressure. Or gastric vessel mucosa can try pulling tension on the bumper temporarily. Careful not to cause necrosis. If that fails, remove tube, endoscopic control, endoscopic sphincterotomy during ERCP, similar bleeding rate 2%, often mild, stops on its own. Delayed bleed within 48 hours might need repeat scope, epinephrine injection. Surgery rarely needed. We mentioned iatrogenic hemophilia, especially after liver procedures, and bleeding from surgical suture or staple lines after gastric or intestinal surgery. Risk reduction strategies from bariatric surgery help keep BP under 140, use staple line reinforcement, check lines carefully at lower pressure during laparoscopy. Most resolve without reoperation. Reoperation is rare, less than 1.4%. Variceal hemorrhage, a different beast.
Okay, huge pivot now. Variceal bleeding. Completely different cause, right? Not erosion, more like
Yeah.
a pressure problem.
Exactly, fundamentally different. Variceal bleeding stems from portal hypertension, abnormally high pressure in the portal venous system. Can be prehepatic, clot in portal splenic vein, intrahepatic, cirrhosis by far the most common cause, or posthepatic, Budd-Chiari, hepatic vein obstruction. Portal hypertension, defined as a pressure gradient, HVPG over 5 mm Hg, but you usually need a gradient over 10-12 mm Hg to actually develop varices that risk bleeding. Basically, there's increased resistance to flow through the liver in cirrhosis. Blood backs up, engorges collateral veins, pathways around the liver, especially in the esophagus, stomach, rectum, made worse by fluid retention, expanded plasma volume, and vasodilation in the gut circulation, all common in liver disease. These veins swell up, sometimes huge, 1 and 2 centimeters, wall tension increases. Then the thin lining over them breaks and catastrophic bleeding happens. Despite progress, acute variceal bleed still has a scary 6-week mortality, maybe 10-20%. So prevention is key. Identifying who's at risk. Tools like transient elastography measure liver stiffness. High stiffness, 15-20 kPa, suggests advanced liver disease, warrants an EGD to look for varices, and maybe measure the pressure gradient directly. EGD findings guide prevention, no varices. Scope again in 2 years, small varices, scope annually. If they have high-risk signs, red wheel marks, consider starting a non-selective beta blocker. Medium or large varices definitely need prophylaxis, either non-selective beta blockers, propranolol, nadolol, carvedilol, or prophylactic endoscopic banding.
So when the crisis hits, when they actually bleed acutely, how is that managed, especially considering the liver disease often means clotting problems too?
ABCDEs are paramount, maybe even more so. Variceal bleeds can be incredibly fast, and patients often do have underlying coagulopathy, low platelets from the liver disease. Goal is always tissue perfusion. Transfusion strategy is careful. We aim for a hemoglobin between 7 and 8 GDL, that restrictive strategy again. Why? Because overtransfusing can actually increase portal pressure and make bleeding worse, reversing coagulopathy. Best evidence isn't totally clear, but we generally aim for an INR under 2, platelets over 50,000. Vasoactive drugs are crucial. Start them immediately if you suspect varices terlipressin, somatostatin, octreotide. Continue for up to 5 days. They constrict blood vessels in the gut, reduce flow, lower portal pressure, and absolutely vital, antibiotics. Any patient with cirrhosis and UGI needs prophylactic antibiotics. Prevents deadly infections like SBP, spontaneous bacterial peritonitis, usually oral quinolones or IV ceftriaxone.
That Sangstein Blakemore tube for mechanical tamponade sounds pretty traumatic, like a last resort.
It is a temporary measure, yes. For really unstable patients, it's a bridge to definitive therapy. It's a tube with 2 balloons, gastric and esophageal. Inflate the gastric balloon, pull tension to compress the GE junction, often stops the bleed. If not, inflate the esophageal balloon. But it's temporary. High rebleed rate, over 50% when deflated. Big risks too, esophageal injury, necrosis from pressure. Newer self-expanding esophageal stents are being studied, look promising, but still experimental mostly. Endoscopic therapy is the first recommended step once stable. For esophageal varices, banding endoscopic venous ligation is preferred over sclerotherapy. Better safety, similar effectiveness for definitive long-term control. Early TIPS, transjugular intrahepatic portosystemic shunt. That's the game changer.
TIPS. We hear that acronym a lot with liver disease. What exactly is it? How does it work?
TIPS is truly revolutionary for portal hypertension. Done by interventional radiology, usually within 24 hours for high-risk patients, 72 hours for others. They create a shunt, a tunnel inside the liver, connects a hepatic vein, draining blood out, to a portal vein, bringing blood in. They place a stent through the liver tissue to keep this channel open. By creating this bypass, it directly lowers the pressure in the portal system, stops variceal bleeding in over 90% of cases, can be life-saving salvage therapy, but it has risks. Increased risk of hepatic encephalopathy, brain fog from toxins bypassing liver, technical risks like bleeding, shunt clotting, or narrowing. Contraindications include severe heart failure, pulmonary hypertension. Predictors of failure include very high pressures, high MELD score, severe cirrhosis, active bleeding during the procedure. Surgical shunts used to be common, creating connections between portal and systemic veins. Effective long-term, but very high mortality acutely, 50%. Non-selective shunts drain everything. Selective ones, like distal splenorenal shunt, just decompress the gastroesophageal varices, maybe less encephalopathy. Non-shunt operations. Things like esophageal transection or the Sudura procedure, devascularization, reserved for dying patients failing everything else. Exceedingly rare now, because TPS works so well at decompressing the portal system with much lower upfront risk. Operative shunts are way less common now, and non-shunt operations are almost never done. TPS really changed the landscape, exploring the lower GI tract, specific LGI causes and management.
Okay, we've thoroughly explored the upper GI. Let's head south now, past the ligament of Treitz. Lower GI bleeds, how do these differ? Presentation, causes, management.
Right, LGB. Technically, anything distal to the ligament of Treitz. Practically, often means bleeding distal to the ileocecal valve, because small bowel bleeds are a bit different from colonic ones. The classic presentation. Painless hematochezia. Bright red blood, clots, maybe burgundy stools. Different from the black melena of UGIB, but remember that crucial overlap. Brisk UGIB can cause hematochezia. So ruling out an upper source is always step one, especially if unstable. Melena can happen with slow LGB, but it's less common. History and exam give clues. Abdominal pain with diarrhea. Think colitis, inflammatory, ischemic, infectious. Changes in bowel habits, weight loss, anemia. Worry about malignancy, epidemiology. LGB is less common for hospitalization than UGIB. About 30-40% of all GIB. Incidence may be 35 per 100,000 people per year. Mortality is lower too, under 2%, but jumps to 5% in the very elderly. Over 95% of LGB sources are in the colon. Risk goes up with age. Causes vary with age too. Diverticular and vascular lesions are more common in middle-aged and older adults. Kids. Think intussusception, young adults, meckel diverticulum. Presentation ranges from massive bleeds, diverticular, vascular, to minor fissures, hemorrhoids. Diagnosing LGI can be trickier than UGI. The tests aren't always as sensitive or specific. Bleeding is often less severe, more intermittent, might stop on its own before you find it. Plus, over 40% of patients might have multiple potential bleeding spots found, so you have to be sure which one is actually bleeding before doing something aggressive. It's a real challenge. The source stays unidentified in up to 25% of LGI cases. The overall approach starts the same. ABCDEs, resuscitation, reverse anticoagulants, except maybe aspirin in high-risk heart patients, fix coagulopathy. First diagnostic steps. Rule out anorectal causes, rectal exam, endoscopy, sigmoidoscopy, treat if found. Then rule out that UGI source. Remember, up to 15% of hematochezia is UGI. Bilious, clear NGT helps. Maybe even a pre-op EGD if heading to surgery for life-threatening LGI. Then severity guides the next steps. Minor LGI, stable patient, can often be worked up outpatient. Think anorectal, IBD, infection, AV malformations, polyps, cancer. Major LGI, unstable, needing blood, 2 units. Massive LGI, needs 2 units. The truly unstable, ongoing, massive bleed, unresponsive to resuscitation. Straight to the OR. Maybe hybrid OR for angiography alongside surgery. Introp-op endoscopy can help too. If the patient responds to resuscitation, becomes stable, then you can be more directed. Colonoscopy is the mainstay. Allows diagnosis and therapy for colon, rectum, distal ileum, but only after a good bowel prep, that rapid prep again, ideally within 24 hours. Endoscopic therapy for LGIB works well, 92% hemostasis. Read bleed rates, 8-12%. Diverticular are the most common source. Even if not actively bleeding, if you see high-risk signs, visible vessel, clot, treat it. Tattoo the spot with ink for later. Other therapies, polypectomy, injection, heat, APC, clips, banding for hemorrhoids, rectal varices.
Does angiography work better with faster bleeding for LGIB too?
Yes, absolutely. Angiography needs active bleeding to see the contrast leak out, so it's best for brisk bleeds. If colonoscopy fails or bleeding is massive, angiography is key, often helped by prior CTA or TAG scan to narrow down the area. Super selective embolization can target just one bleeding diverticulum. Techniques are the same as for UGIB. Usually check SMA first, right colon, then IMA if needed. Success for embolizing diverticular bleeds is near 100%, rebleed rates very low, maybe 0%. Other tools. Tagged RBC scan is positive in maybe 40% of LGIB, some false positives, but good for intermittent bleeds because you can stand repeatedly. Capsule can sometimes see bleeding in a prepped colon too.
When does LGIB require surgery? What are the criteria for operating?
Surgery is for persistent instability, despite resuscitation, needing 4 units of blood in 24 hours, or 10 units total during the hospital stay. And again, preoperative localization is absolutely crucial. Without knowing where the bleed is, the only option is that blind total abdominal colectomy with ileostomy. It's a big operation. High morbidity mortality, 20-30% emergently. And even then, segmental resection has a higher rebleed risk, 18%, Venice 4% for total. Usually avoid anastomosis in unstable patients due to leak risk. Other surgical considerations: oncologic resection if cancer is found and patient is stable, damage control surgery for dying patients, stop the bleed fast, stabilize, plan definitive surgery later. Specific causes of lower gastrointestinal tract bleeding.
So diverticular, you said the most common cause of significant LGIB in the U.S.
Yes, that's right. Affects 3-15% of people who have diverticula. Prevalence skyrockets with age 20% at 40, 60% plus at 60, seeing it more in under 40s too now. They form where blood vessels, vasa recta, pierce the muscle layer. As the pouch expands, the vessel gets stretched, damaged, ruptures. Left-sided disease is more common in the West, but paradoxically, right-sided diverticula cause over 50% of the significant bleeds. Most bleeds, 75%, stop on their own, but rebleeding is common, 10% within a year, 50% within 10 years for some. Diagnosis and therapy: colonoscopy is best, endoscopic treatments like we discussed, injection, heat, APC, clips. Clips help mark the spot. Treat active bleeding or high-risk stigmata. Combine epinephrine with another method. Tattoo if no clip. Recurrent bleed. Repeat scope or angiography. Angiography allows super-selective embolization. Clips help guide them. Surgery is the last resort. Patient must be unstable despite everything. Must localize. First rule out upper small bowel. Find the right spot. Blind total colectomy is high risk, 4% rebleed. Segmental has higher rebleed risk, 18%. Tough call. Colitis colon inflammation can be from IBD, infection, radiation, ischemia. Ulcerative colitis, UC. More likely to bleed than Crohn's. Most UC patients have gross bleeding sometime. Major acute bleed is rare though. It's mucosal disease, starts in rectum, spreads up. Bloody diarrhea, cramps, tenesmus. Diagnosed with history, scope, biopsy. Treat with supportive care, steroids, 5-ASA, biologics, etc. Bleeding is usually diffuse, no single spot to treat endoscopically. Surgery, colectomy, occasionally for bleeding, more often for toxic megacolon or refractory disease, Crohn's disease. More often guaiac-positive diarrhea, mucus, less gross blood. Can affect anywhere, mouth to anus. Skip lesions, transmural inflammation. Diagnosed with scope, biopsy, imaging. Treat similarly steroids, 5-ASA, biologics. Significant bleeding needing intervention is rare, but Crohn's is more likely to cause discrete lesions like deep ulcers eroding a vessel, which can be treated endoscopically or angiographically. Strictures can make scoping hard. Angiodysplasia, arteriovenous malformation, AVM. These are acquired degenerative lesions, dilated submucosal vessels, different from true congenital AVMs. Can be anywhere, but typically the cecum is the most common bleeding site.
And these get more common with age.
Yes, definitely increase with age. Also associated with aortic stenosis and kidney failure. No gender difference. Presentation is usually painless, self-limiting, intermittent bleeding similar to diverticula, but it tends to be venous bleeding, so often less brisk, more occult or chronic. Can be significant in up to 15% though. Diagnosed with colonoscopy, you see flat, bright red, star-shaped lesions. Angiography, slowly emptying veins, or CT. Incidentally found ones don't need treatment. If bleeding, endoscopic thermal therapy, APC preferred. Angiography also an option. If localized bleeding fails or recurs, segmental resection, usually a rate colectomy, is effective. Neoplasms in the lower GI. Colon cancer is an uncommon cause of significant LGI. Bleeding is usually slow, intermittent, painless. Colonoscopy is gold standard for diagnosis, unless massive bleed. CTA, angio, emergent surgery for massive bleeds. G's, the GI stromal tumors, most common sarcoma in GI tract, 20-30% present with bleeding. More common in stomach, small bowel, but can be in colon. Tumor erodes vessel or disrupts blood supply. Endoscopy best for diagnosis. Treatment is oncologic resection. Small bowel tumors, uncommon but cause occult or frank jab. Diagnosed with small bowel imaging, CTM or enterography capsule. Treatment is surgical resection. Intestinal polyps. Rare cause of acute bleed, more often bleed after polypectomy, iatrogenic. But second most common cause of bleeding in kids. Treat bleeding polyps endoscopically. Ischemia, insufficient blood flow, causes. Shock, low flow states, vascular disease, embolism, vasopressors, vascular surgery. Suspected in patients with cardiovascular history, PVD, vasculitis, recent vascular surgery. Shock, hypercoagulable states, high-dose pressors. Acute colonic ischemia is most common type. Often watershed areas, splenic flexure, rectosigmoid, but can be right-sided, 40%. Classic presentation, pain out of proportion to exam. Diarrhea, often bloody guaiac positive for mucosal sloping. Diagnosed with CT, bowel wall thickening pneumatosis confirmed with flexible endoscopy, see abnormal mucosa. Treatment is supportive. Bowel rest, IV antibiotics, BP support, fixed low flow state. 85% resolve on their own, 15% needs surgery for gangrene. Indicators for surgery. High WBC fever, ongoing resuscitation needs, acidosis, severe pain. Infectious colitis can bleed. Diagnosis is based on history, labs, cultures. C, difficile after antibiotics. Explosive, sometimes bloody diarrhea, mucosal sloughing, high WBC, foul smell. Treat by stopping antibiotics, supportive care, metronidazole, oral vancomycin, or fidaxomicin. Cytomegalovirus, CMV. Suspect and immunocompromised with bloody diarrhea, diagnosed with endoscopy biopsy, treat with IV ganciclovir, Meckel diverticula, and small bowel diverticula. Meckel's is congenital remnant, may have ectopic gastric tissue, bleeds from ulceration of adjacent ileum from acid, painless LGIV, often younger people. Diagnosed with capsule, CT, angiography, look for vitelline artery. Meckel's scan, technetium, shows ectopic gastric mucosa. Treatment is surgical resection of the segment, including the ulcer. Small bowel diverticula occasionally bleed, often occult. Diagnosed with history, capsule, angio. Treatment is surgical resection. Radiation therapy causing radiation proctitis enteritis. Complication of pelvic radiation, 1 to 5% risk. Bleeding from mucosal changes, fragility, angioptasias, ulcers seen on scope. Treatment guidelines recommend topical formalin, sucrafate enemas, hyperbaric oxygen. Endoscopic therapy, APC, works but risks fistula stricture, 3%.
Wow. That was an incredibly deep and comprehensive dive into acute gastrointestinal hemorrhage. From the absolute basics, the ABCDEs, right through to the really fine distinctions between, say, a duofoy lesion and diverticular bleeding. We've covered so much ground. True mastery-level detail.
It really does underscore the complexity of the entire digestive tract, doesn't it? And the absolute necessity of that rapid, coordinated, multidisciplinary approach. The progress, though, advancements in diagnosis, targeted therapies like PPIs, interventions like TIPSS, they just profoundly improved outcomes. It's remarkable.
What really strikes me is how one symptom bleeding can stem from such a vast array of causes, each with its own unique pathway for diagnosis, its own specific treatment strategy. It really speaks to how specialized and precise modern medicine has become.
Absolutely. And connecting it back to that bigger picture, it highlights that constant interplay. Rapid assessment, precise localization, then tailored intervention. Critical thinking, understanding the nuances at each step, is just essential for navigating these high-stakes scenarios successfully.
So for you, Our listener, working towards mastering this, what does it all boil down to? Maybe a deeper appreciation for the body's intricate systems. Or maybe just insight into the incredible speed and precision needed in emergency and critical care medicine.
And perhaps this raises an important question for you to consider further to really solidify that mastery. With diagnostic imaging and endoscopic techniques constantly advancing, especially for those tricky small bowel bleeds, how do you see the role of traditional open surgery evolving over the next decade for complex, unlocalized GIB? Will it become even rarer, an absolute last resort, or will its role shift, perhaps towards more specialized, maybe hybrid procedures tackling challenges beyond our current non-surgical reach?
A great question to leave you with, something to mull over. Thank you for joining us on this absolutely vital deep dive. We hope you feel not just well-informed, but truly equipped with a mastery-level understanding of acute gastrointestinal hemorrhage. See you next time.